Hello and welcome to my channel. This lecture will be discussing the spinal cord, so let's begin. The spinal cord, I told you before, it's sometimes called the medulla spinalis because it's an extension or a continuation of the medulla oblongata in the vertebral canal of the vertebral column. The external features of the spinal cord, this is a specimen of the spinal cord. This is the posterior surface you're looking at, and there is the anterior surface. It has an anterior median fissure and posterior median sulcus. The gray matter lies in the center and the white matter at the periphery in the form of funiculi. Anterior funiculus, posterior funiculus, and lateral funiculus. And the gray matter is roughly H-shaped. It has a posterior horn or dorsal horn and a ventral horn, and in some parts of the spinal cord it has an extra lateral horn. Now it extends from the foramen magnum till the level of L1, L2. The end of it is the conus medullaris. This is the end of the spinal cord. The conus medullaris lies at the level of L2. But be careful, in children, it's slightly lower down at the level of L3. So be careful when you operate for a lumbar puncture, for example. It has a cervical enlargement and lumbar enlargement to provide an space for the cells of the upper limb and the lower limb. For the upper limb forms the cervical enlargement, and the lower limb forms the lumbosacral enlargement. It's divided into segments. Each spinal cord segment is an area of the spinal cord that give rise to a pair of spinal nerves. So from here till here, this is a spinal cord segment, because you see these are the rootlets of this spinal nerve, and these are the rootlets of the opposite spinal nerve. So these are the spinal cord segments. It's important to examine the dermatomes of the patient to know if you suspect a lesion in the spinal cord, to know at which level this lesion is. That's why it's crucial to test the dermatomes of the patient. Spinal nerves, they arise by a series of rootlets, as you can see here, that form a single root, and then the roots, the dorsal root and the ventral root, they unite to form the spinal nerve. Please observe that higher up, the roots of the spinal nerves are almost horizontal and short. But as you go down, the roots becomes longer. See? Roots become longer because the growth rate of the vertebral column exceeds that of the spinal cord, and these are the roots, very long roots of the spinal nerves that are going to the lower limbs. In this area you will find only roots for the spinal nerves going to the lower limb, and the end of the spinal cord hangs up between the level of L1 and L2. The roots lower down, because they are almost vertical, not horizontal and long, they form, they're shaped like the horse tail. That's why they are called the cauda equina, the horse tail, the cauda equina. This area between the L2 and the S2, where the dura and arachnoid fuse together, is filled with CSF, of course continuous with the subarachnoid space above, but I mean here it's a collection of the CSF. So this is the site where you obtain a lumbar puncture either to introduce anesthesia or dye to perform a myelogram, or even to introduce drugs like antibiotics if you suspect meningitis. C1 through C7 rise above their vertebra. Remember, C1 nerve is above C1 vertebra, and C2 until C7, but C8 nerve, please observe that we have 8 cervical nerves and 7 cervical vertebra. C8 is below C7, and from there downwards, each nerve is below its vertebra. I mean T1 nerve below T1 vertebra, and so forth. Okay. To calculate the segment, to estimate the segment levels according to vertebra, higher up at T1 vertebra, just add 1, so you are at T2 spinal cord segment. Lower down at T6 vertebra, you add 2, so you are at T8 spinal cord segment. The same principle here at T10, you add 3, you are at L1 spinal cord segment, and you know it ends between L1 and L2 vertebra. We talked about the rootlets and the roots. Now, I want you to recognize the difference between rami and roots. See, this is a dorsal root here. This is a ventral root. They unite together to form the spinal nerve, and there's a bulge on, or swelling on, the dorsal root. It's called the dorsal root ganglion. After emerging from the intervertebral foramen, the nerve divides into anterior ramus and posterior ramus. Posterior rami, they never form plexuses, but anterior rami, they are the ones that form plexuses, like the brachial plexus, cervical plexus, lumbosacral plexus we studied in anatomy. So please distinguish the difference between the rami and the roots. Okay, roots are inside the vertebral canal, and rami are outside the vertebral canal. There's also the gray rami communicantis and the white rami communicantis. These are the afferents and efferents from the sympathetic chain. So don't confuse these with the anterior and posterior rami of spinal nerves. So you have rami of the sympathetic chain, you have rami of the spinal nerve, and you have roots that form the spinal nerve. A lower motor neuron is the motor neuron responsible to supply a certain group of muscle fibers, and the area of skin supplied by a cutaneous nerve is called a dermatome. So the dermatome is an area of skin that supplied by a certain cutaneous nerve. And I told you before, in order to determine the level of injury in the spinal cord, you examine the dermatomes all over the body. The myotome are the muscle fibers, is the muscle fibers supplied by a single spinal cord segment. Reflex arc, you'll find this in neurophysiology. Afferents come through the dorsal root to enter the dorsal horn, and through interneurons in the middle, they convey the impulses to the ventral root and then to the muscles involved at the side of the stimulus. This is called the reflex arc, okay, or reflex arch. Spinal cord is continuation of the brainstem, so it's covered by meninges, the same meninges, the dura, arachnoid, and pia maters. The dura mater is one layer It attaches to the margins of the foramen magnum upwards, and intervertebral foramina at the sides, at the sites of exit of the spinal nerve. It forms a sleeve, small sleeve around the beginning of the spinal nerve. The epidural space is filled with fat and vertebral venous plexus, and the dura and arachnoid, they fuse together at the level of S2. Arachnoid is a continuation of the cranial arachnoid. Sorry about this mistake here. It's continuation of cranial arachnoid, not dura. It's adherent to dura, and it forms sleeves around, also sleeves around the beginning of the spinal nerve. That's why in myelogram, when you inject a dye in the lumbar cistern, you get a picture dentated like the same figure you see here. See, but these dentations are formed by the pia mater. Actually, the dentations in the myelogram are the dye entering the sleeves at the beginning of the spinal nerve. So there is a difference between these dentations and the dentations you observe in a myelogram. Contains the subarachnoid space, contains the CSF, of course, and it collects downwards below the level of L2 till the level of S2 into the lumbar cistern, and this is the site for the lumbar puncture, either for sampling or drugs or anesthesia, and even to inject a dye to visualize the spinal cord, as in the procedure of myelogram. The pia mater is adherent to the spinal cord. It forms what's so-called the denticulate ligament. See, this is the denticulate ligament. Going laterally, projects laterally, and fuses with the dura. Between the spinal nerves, please don't get confused with that of the myelogram again. Between spinal nerves, see that? Between spinal nerves, it attaches to the dura mater. That's why it's called dentate or denticulate ligament. It forms distally, forms the filum terminale. See, this is the filum terminale. The filum terminale pierces the dura and arachnoid mater at S2 and continues downwards, and also to be attached to the back of the coccyx. Now, for this arrangement, it has an inner part and an outer part. So the inner part is called the filum terminale internum, and the external part is called the filum terminale externum. This is the arrangement of the pia mater. Factors fixing the spinal cord in place inside the vertebral canal. The dura, as mentioned, it's attached to the foramen magnum and the intervertebral foramina. This fixes the spinal cord. Also, the denticulate ligament fixes the spinal cord. The filum terminale fixes the spinal cord, and the exit of the spinal nerves also fixes the spinal cord in place. That's why it won't get incarcerated with the movements of the vertebral column. Internal structure of the spinal cord, it's opposite of that of the brain. I mean, the gray matter is in the center and the white matter at the periphery. The white matter forms funiculi, dorsal funiculus, ventral funiculus, and lateral funiculus. The gray matter, as you can see here, it resembles the letter H. It has a dorsal horn and a ventral horn, and it differs in size and shape according to the level. This is the cervical region, this is the thoracic region, the lumbar region, and the sacral region. But please observe the ratio between the gray matter and white matter. it's at its maximum in the sacral region, means the gray matter ratio to the white matter is the at its peak or greatest. It gets, you know, lesser and lesser as you go up, and here in the cervical region the white matter is more than the gray matter, because this is logic. This makes sense. The sensations from all over the body are gathered on their way up to the brainstem, and are collected on their way up to the brainstem and the brain. In some regions of the spinal cord, you will find an extralateral horn like this one, and in the upper region of the lumbar segments in L1 and L2. These contains the cells of the autonomic type. In the thoracic region, it gives this is the source of the sympathetic outflow, and in the lumbar in the sacral region, here also they have a lateral horn. It's the source of the parasympathetic outflow, S2 and 3 and 4. Okay, so you have a lateral horn from T1 through L2, and from S2 through S4, but they differ in function. Those in the thoracolumbar region for the sympathetic outflow, and those in the sacral region for the parasympathetic outflow. You can estimate the region of the spinal cord. You know, in the cervical region, the white matter is in big ratio or great ratio to the gray matter, and the gray matter forms a shelf here at the ventral horn. It's called shelving. So that's how you distinguish a cervical region. The thoracic region is roughly an H shape, almost straight dorsal horn and ventral horns. They are this almost the same thickness. In the lumbar region, they are thick dorsal horn and thick anterior horn, and in the sacral region, of course, you have the gray matter is in great ratio to the white matter, and thick or big dorsal and ventral horns. That's how you distinguish the regions of the different levels of the spinal cord. There is an arrangement also thrown into Lamina 1 through 10 by Rexed. It's called Rexed's Lamina. These lamina define the collections of neurons in 10 lamina. See the dorsal one being number 1, and the one around the central canal is Rexed's Lamina 10. This is another arrangement than the one you see here, for example. Okay, anterior horn cells. We have anterior lower motor neurons. Types of these motor neurons are alpha and gamma motor neurons. The alpha motor neurons send fibers to skeletal muscle fibers. The gamma motor neurons, they also send it to the skeletal muscle, but to the muscle spindle, to the intrafusal muscle fibers of the muscle spindle, to control the muscle tone. So remember, alpha and gamma motor neurons. The lower motor neurons, they divide into 3 groups: lateral, medial, and central. And I want to tell you something about the lesions paralysis, for example. A lower motor neuron lesion differs than the upper motor neuron lesion. What do we mean by the upper motor neuron? It's the fibers coming from the motor cortex to the lower motor neuron. It has almost always an continuous inhibitory effect because of the active muscle tone, active gamma neurons in these neurons. So when you cut the upper motor neuron, for example, there's an injury at a level below it, the lower motor neurons will be hyperactive. So that's why the type of paralysis differs. It's spastic paralysis. But injury, at the site of injury, the lower motor neuron will be injured. And this way, there will be no muscle tone in the muscle involved. So the type of paralysis will be flaccid paralysis. So this is the difference between upper motor neuron lesion and a lower motor neuron lesion. And it's always mixed with spinal cord injury. At the site of injury, it's a lower motor neuron. Below the injury, the muscles affected are in an upper motor neuron lesion injury. The lateral group of the lower motor neurons, they are in the cervical region for the upper limb and in the lumbosacral region for the lower limb. Extensors, those that supply extensor muscles being anterior. Those that supply flexor muscles are posterior. Distal muscles are lateral and proximal muscles are medial. The medial group, they present at all levels because they supply the axial muscles of the neck, head, and trunk, intercostals, and abdominal muscles. The central group, there are collections of motor neurons in certain regions of the spinal cord. For example, from C3 through C5, these are the source of the phrenic nerve that supplies the diaphragm. From C1 through C6, the spinal accessory component of the accessory nerve that enters, we studied this in anatomy, it ascends in the vertebral canal and enters the foramen magnum and unites with the cranial part to form the accessory nerve. By the way, in some specimens, I dissected accessory nerve, spinal accessory nerve coming directly from the vertebral column. I mean, it didn't go to the cranial cavity. Of course, the accessory goes to trapezius and sternocleidomastoid muscles. Those collection of some neurons at L2 through S1 in the it's called the lumbosacral nucleus. It's probably as one of the automation centers for movements that's concerned with the lower limbs. There are automation centers in the spinal cord that make sure that the limbs are or coordinate the movements of the limbs together during walking and running, for example. The motor unit is the lower motor neuron and the muscle fibers supplied by this lower motor neuron. Together they are called the motor unit. Posterior horn cell groups, we have dorsomarginal or lamina 1. At all levels, it receives afferents for simple touch, pain, and temperature. And lamina 2, adjacent to it, is the substantia gelatinosa of Rolando. It's rich of substance P as the neurotransmitter. It's the neurotransmitter of pain. Remember that. Substantia gelatinosa of Rolando in lamina 2 at all levels and receives afferents for pain, temperature, and simple touch. Efferent is the spinothalamic tract, and we will study this in the next lecture in the tracts or tractology of the spinal cord. A nucleus proprius in the lamina 3, 4, and 5. C, nucleus proprius. Anterior to substantia gelatinosa of Rolando and the same afferents as that of the SGR. Nucleus dorsalis at the base of the dorsal horn at lamina 7 from T1 through L3. It receives proprioception and projects as efferent, gives efferent fibers in the form of the dorsal spinocerebellar tract that enters the cerebellum through the inferior cerebellar peduncle. Also, there are a collection of neurons, the visceral afferent nucleus in lamina 7. Also, it's lateral to nucleus dorsalis and receives visceral afferent information. Lateral horn cell groups. We have intermediomedial and intermediolateral cell groups. I told you before, it's for autonomic function. And in the thoracolumbar region, it's responsible for the sympathetic outflow. In the sacral region, it's responsible for the parasympathetic outflow. Intermediate zone, central canal in the middle. This is the intermediate zone. It has as associative neurons and tracts crossing in anterior and posterior commissures, anterior and posterior to the central canal, may be affected in some cases like syringomyelia, for example. And those that cross for the pain and temperature, so there will be a loss of pain and temperature in syringomyelia. Well, this is a brief anatomy of the structure of the spinal cord. I hope you got the maximum benefit from this lecture, and thank you very much for watching.